All right, well, I just want to welcome everybody back from break. And we have a really exciting resident paper session. And I'm going to introduce our first speaker, and it's Dr. Alex Marks, and he's going to be speaking about revision rates and trends in diagnosis and management of combined ACL and MCL injuries.
Get to start off their presentations as well. All right, so as Dr. Laroque said, I'll be talking about the following topic, no relevant disclosures. And as we all know, combined ACL and MCL injuries represent the most common variant of multi-ligamentous knee injuries, with the current treatment algorithm traditionally being for grade 1 injuries, MCLs are managed non-operatively, while operative management of the MCL is reserved for higher grade injuries. However, trends and outcomes based on the management of MCL injuries at the time of ACL reconstruction have not been extensively studied. And so the objectives of our project was to compare rates of revision between patients with isolated ACL reconstruction to those who had concomitant MCL injuries managed either operatively or non-operatively at time of index ACL reconstruction. We hypothesized that patients with concomitant injuries, particularly those who had surgery for their MCLs, would have worse outcomes. And so to do so, we used the ProDiver database and queried all patients who underwent ACL reconstruction between 2016 to 2020 with 2-year minimum follow-up. And patients were further divided by injury pattern into subcohorts, with isolated ACL injury being one cohort, and then concomitant ACL and MCL injury being the second cohort. And the concomitant injury cohort was divided further into non-operative management of the MCL, MCL repair, or MCL reconstruction. And the patients were excluded if they had a primary diagnosis of knee dislocation or subluxation, PCL, LCL, or PLC injury, concomitant HTO, DFO, or prior ligamentous reconstruction or repair. Baseline demographics of age, sex, BMI, tobacco use, and Charleston Comorbidity Index were queried, as well as rates of complications and need for revision ACL reconstruction. We used t-test, ANOVA, and chi-square tests as appropriate to identify or to compare our identified patient cohorts and analyze trends. And then multivariate logistic regression was used to assess the association between demographics and isolated ACL injury versus ACL injury with concomitant MCL injury, isolated ACL injury versus ACL injury with concomitant non-surgically treated MCL injury, operatively treated MCL injuries versus non-operatively treated MCL injuries, and then lastly, MCL repair versus MCL reconstruction. And so moving on to results, a total of 58,152 ACL reconstruction patients were identified with the database. Of those, 47,000 patients had isolated ACL injuries and 10,000 had ACL injuries with concomitant MCL injury. The cohorts were similar in baseline demographics. And amongst the 10,846 patients with concomitant MCL injuries, 93% were treated non-operatively, 4.7% were treated with repair, and 2.7% were treated with MCL reconstruction at the time of index ACL reconstruction. And despite the majority of MCL injuries being managed non-operatively, the annual proportion of patients being surgically managed for their MCL injury increased by 70% over the study period, from 5.5% in 2016 to just over 9% in 2020. Moving on to complications and revisions, patients with concomitant MCL injuries had higher rates of ACL revision surgery at 1, 2, and 5 years after index ACL reconstruction, with 4.7% of patients with initial concomitant MCL injury undergoing revision at 5 years compared to 3.2% of patients with isolated ACL injuries. Amongst patients with concomitant MCL injuries, patients who'd undergone MCL reconstruction had higher rates of ACL revision compared to non-operatively managed patients and MCL repair patients at 1, 2, and 5 years after index ACL reconstruction, with over 10% of patients who underwent both ACL and MCL reconstruction at 5 years requiring subsequent revision surgery, revision ACL reconstruction, And then regarding meniscal injury, concomitant MCL injuries had higher rates of meniscus tears as well as subsequent meniscectomy or meniscus repair. And the knees that underwent MCL reconstruction had higher rates of meniscal pathology and subsequent meniscectomy or repair. However, when comparing ACL reconstruction and non-operatively treated MCL injury with ACL reconstruction, the operatively treated MCL injuries to operatively treated MCL injuries, there was no difference in subsequent meniscal surgery. Stiffness was also a large factor with ACL-injured knees and concomitant MCL injuries, with the concomitant injuries having higher rates of postoperative stiffness and subsequent MUA and lysis of adhesions. And then operatively treated MCL injuries were more likely to undergo MUA and lysis of adhesions than non-operatively treated MCL injuries. In our multivariate logistic regression analysis, patients with concomitant MCL injuries had an increased likelihood of requiring revision ACL surgery with an odds ratio of 1.5. Tobacco use, longer age, and higher CCI were also negative independent risk factors for revision ACL reconstruction. And then similar measures of association were found when comparing isolated ACL injured patients to concomitant MCL injured patients that were treated non-operatively for their MCL, with non-surgically treated MCL injuries having an increased likelihood of requiring ACL revision surgery. Amongst patients with concomitant MCL injuries, patients with MCL surgery had higher odds of revision ACL reconstruction with a ratio of 1.39, with age, BMI greater than 30, and tobacco use remaining as significant risk factors for revision. And then lastly, among patients who had their MCL injuries managed surgically at time of index ACL reconstruction, MCL repair patients had significantly lower odds of ACL revision surgery compared to the MCL reconstruction patients. So in conclusion, despite an increase in operatively managed concomitant MCL injuries, the majority of concomitant MCL injuries are still managed non-operatively at time of ACL reconstruction. And patients with concomitant MCL injuries, particularly those managed operatively at time of ACL reconstruction, are at increased risk of requiring revision ACL reconstruction compared to those with isolated ACL injuries. Thank you.